Good afternoon. Welcome to Dental XP. My name is Dwayne Caratu. I'm a practicing dentist in Vancouver, British Columbia, Canada. Trained in periodontics, prosthodontics at the University of Pennsylvania. So I had the good fortune to know Henry, David, and Maurice. I've been practicing for over 15 years now. I've been the former director of implant studies at University of British Columbia, and now maintain a solo private practice. Today I want to discuss with you creating a supernatural smile. Soft tissue and ceramic design is paramount with that. Of course, when we're talking about the smile, we're really discussing the anterior 6 teeth, or perhaps extending it to include both premolars, so 7 and 8 teeth total. It is within that frame that we look to what we can do and what we can create, as well as what's happened in the past. And we learn our best lessons from those mistakes that have happened in our offices. A situation which was presented to me was a failing implant with soft tissue concerns on this maxillary central incisor. We look at that and we recognize from the soft tissue profile that there are some difficulties. And in fact, when we take a lateral view, we can notice there's suppuration. Why is this happening? The profile of the buccal shelf looks adequate. The convex profile of the tooth, again, looks adequate. However, to elucidate what has happened, we must remove the crown and observe the clinical situation. The culprit in this particular situation was trapped cement and a buccal ceramic shelf. Both of those absolute contraindications for implant success and implant aesthetics. We removed the crown and created a flipper type apparatus to support the tissue in the next healing phase. We did this in order to create a more positive architecture of the soft tissue and perhaps restore it again with a new crown and abutment situation. We were able to achieve this in a matter of weeks, completed a Procera abutment, and put on an all ceramic restoration, thereby recreating nature's beauty. In clinical practice, the smile building really is generated from 5 different points. We want to get the proper length of the teeth. We get that facially from the lip. We want to create dominant centrals, harmonize with the face, a convex smile line, create nice incisal embrasures, and certainly in the age of aesthetics, we want high brightness to the restorations. How do we achieve this in practice, especially in the anterior aesthetic zone with dental implants? If we have a failing central incisor like this with a soft tissue profile that perhaps is not the best, we want to extract the tooth and replace it immediately. We wanted to be a little inventive with this and create a temporary restoration using the patient's own clinical crown. Simply made a GC index prior to extraction of the tooth, and you see from the tooth itself there is a fracture evident in the interproximal region. The tooth is removed as atraumatically as possible using either periotomes or other implements. The osteotomy is completed within the extraction socket. The implant is placed, and immediately we custom fabricate a transitional abutment, take her natural tooth, ream it out, reline it with acrylic or composites, and simply cement it back on. This is going to act as a natural scaffold for the soft tissue to heal over time. Often we're asked to create a restoration where we have nothing. In this particular case, it was referred to me from Maurice Salama, and I was able to work with the patient for a number of months. We saw him after stage 2 had been completed and immediately put on a provisional restoration, thereby initially creating the soft tissue contours. Temporary abutment and crown preparations were completed. Go to final restoration, again, a Procera zirconium crown system for both the natural tooth and the implant restoration. When they're placed in the mouth, we have excellent aesthetic results, and we've maintained a gingival harmony. I want to finish this little presentation today by creating a supernatural smile within the clinical environment. A failed lateral incisor, again, we know the tooth is going to come out. We know we want to use the patient's own clinical crown as the provisional restoration. We make a simple GC resin index of the incisal edges. When we place the implant, we want to make sure we're placing it 3 millimeters below the current gingival crest so that we have room to develop a soft tissue emergence profile. The tooth is reamed out, relined with either acrylic or composite, and then simply cemented back on after the stage 1 or the placement surgery is completed. When we look at the situation 3 months later, we know that we have an ideal sulcus form. That is a direct result of using the patient's own tooth. When we come to the final restoration, as you see on the right slide, we've created ideal gingival architecture, maintained the papillas, controlled the buccal soft tissue profile, and further enhanced her entire anterior smile. Certainly appreciative from a number of different viewpoints. A nice clinical situation. Well, I want to thank you for spending this time with me, and I want to thank Dental XP and Marie Solano for all they've done. It's been a wonderful opportunity to share this with you.